Okay. Good afternoon and welcome. The concurrent session that you're all here for is Barriers to Health for First Nations Children and Youth. So, welcome. On behalf of Children's Healthcare Canada and the Family Network, I would like to thank you all for joining us for the session. My name is Natasha Ellis, and I'm a co-chair of the steering committee for the Family Network with Children's Healthcare Canada. I live and work in Winnipeg, Treaty 1 territory, unceded land of the Dakota and homeland of the Métis Nation. And I'm really excited and grateful to be here today as a mother of three and a community member. I also, in my other hat that I wear, I'm a lawyer in Winnipeg. And I'm just really glad that we're having the session today, and I'm proud to be part of this. First Nations children face health disparities due to historical, socio-political, and economic factors rooted in colonization. These issues, including systemic racism and discrimination, poverty, and limited services, lead to mental health struggles, substance use, and developmental delays. Poor infrastructure and healthcare access, along with environmental degradation, worsen health outcomes, and a holistic approach is needed, focusing on cultural restoration, better healthcare access, and sustainable community development. So joining us today, I think I see you back there, are April Kakagumek, the acting Raising Our Children manager, in the Approaches to Community Wellbeing program with Sioux Lookout First Nation Health Authority, and Karen Mikas, the acting associate director for the Sioux Lookout First Nations Health Authority, Approaches to Community Wellbeing. And they're going to expand on the issues and consider solutions to these long-standing issues. So I invite you to explore their full bios on the conference website and help me to welcome April and Karen.
Miigwech, thank you. Buju, hello. We are here today to discuss barriers to health for First Nations children and youth within Northwestern Ontario. Okay, so like she said, Natasha, thank you for the intro. My name is Karen Mikas. I'm the Associate Director of Approaches to Community Wellbeing. Now, that is the public health branch of our organization, and it's a pleasure to be here. I am originally from the Kiowa Nation in Oklahoma, and I have lived in Canada for about 31 years. I started my career as a teacher, and my first job was way up north in Northwestern Ontario, and living in a First Nation community, which was a huge pleasure of mine. And about 15 years ago, switched careers and went into the medical field. So, and here we are. Thanks for having us today. Buju, April Kagamek, Nadijnakas, North Spear Lake, Nadunji, Suloko, Nadijnada, Ojijak, Nadodem. My name is April Kagamek. I come from North Spirit Lake First Nations on Treaty 5, but I live, work, and play in Sioux Lookout on Treaty 3. I've been there for now about 3 years. I am a nurse and just currently in this new manager role, so this is very new for me. We would like to first acknowledge that we are on the traditional unceded territory of the Algonquin peoples of Ottawa, but also like to acknowledge that the Sioux Lookout First Nations Health Authority, as from here on out will be referred to as SLFNA. The Sioux Lookout area and Thunder Bay region are homes to many Indigenous nations, including the Anishinaabe, Cree, and Ojibwe peoples. These lands have been cared for by Indigenous peoples for thousands of years, and their deep connections to the land continues to this day. Awesome. So the Sioux Lookout First Nation Health Authority. From here on, we'll call SLFNA, just like April said. is a regional First Nations governed organization that works to improve the health and well-being of First Nation communities in northwestern Ontario. We have our map here that outlines the 33 communities that we serve. Within SLIFNA, our public health department, the Approaches to Community Wellbeing, is dedicated to promoting health, building capacity within community, and preventing illness through public health initiatives. ACW is focused on supporting the health needs of First Nation communities and their members by using a holistic approach that includes physical health and emotional, mental, and spiritual well-being. Working closely with the community leaders, the elders, the community members, and the health professionals there, ACW helps to build resilience and enhance community-led health initiatives that reflect the distinct need of each First Nation community.
I'm just going to highlight one quick reserve that we have. Fort Severn, right on the very tip, and then Thunder Bay is way down here. And most of you are probably aware of Thunder Bay, I'm hoping. So the next slide. The legacy of colonization continues to profoundly affect First Nations children and youth across generations. At the heart of this legacy was the Canadian government's residential school system, which forcibly removed Indigenous children from their families, communities, and cultural environments. These institutions were not solely about education, but tools of assimilation designed to erase their languages, traditions, and family connections. For over a century, this policy of cultural genocide was systematically enforced, resulting in widespread trauma and disconnection. Beyond residential schools, colonial policies, such as the 60s scoop and forced relocation of communities, have further fractured the Indigenous structures. The impact of these policies are not just historical. They persist today in forms of intergenerational trauma. The pain endured by the previous generations is carried forward, with many children and youth inheriting the emotional weight of their parents' and grandparents' experiences. This trauma continues and contributes to higher rates of mental health challenges, substance use, and family instability. Compounding these emotional and psychological burdens are the structural inequities that many First Nations still face: inadequate housing, lack of clean water, limited access to healthcare, and significant socioeconomic disadvantages. Today, First Nations youth and children face a layered and complex reality where past wounds and present barriers intersect, making the path to health and wellness challenging.
So the social determinants of health refers to the conditions in which people are born, they grow, live, work, and age. These conditions, such as income, education, environment, social support, and the ones highlighted on the screen, exist outside the healthcare system, but plays a crucial role in shaping healthcare outcomes. When these determinants are favorable, they can lead to improved health and well-being. However, inequities, especially rooted in systemic barriers, can lead to health disparities. For First Nation children and youth living on reserve, the impact of these social determinants is deeply influenced by these systemic inequities. Today, many often face barriers such as inadequate access to healthcare and health programs, overcrowded or unsafe housing, limited access to nutritious food and clean water, and underfunded education systems. These are not logistical issues. They are structural barriers rooted in systemic discrimination and a long-standing lack of equitable investment. The health impacts are real and measurable, and we will discuss them in this presentation, and addressing them means addressing both the historical and present-day structures that can support true health and wellness for First Nations children and youth.
Many of our First Nation communities are located in remote areas with limited economic opportunities, and inadequate infrastructures. A high percentage of children and youth in these communities live in low-income households, leading to poor living conditions such as overcrowded housing and inadequate nutrition. These socioeconomic factors are compounded by the limited access to education, healthcare, and other essential services, which restrict the opportunities for growth, development, and well-being. Poor housing quality and underdeveloped infrastructure contribute to a range of health problems, including respiratory issues, infectious diseases such as TB and COVID-19, and developmental delays. Additionally, high food prices and food insecurity make it extremely difficult for families to maintain a nutritious diet. Together, these challenges create a cycle of hardship that hinders the well-being of First Nations children and youth.
Only 7 of the 33 communities in the Suluk region are accessible by road year-round. So for the rest, many communities can only be accessed by plane year-round and by ice road only during the winter times. This geographic isolation results in delays in treatment and the provision of preventative services. Additionally, this region faces significant shortages of healthcare professionals, made worse by the high turnover rates. This staffing shortage limits the availability of services and directly impacts on the quality of care. Families are often required to travel long distances to urban centers for specialized consultations and treatments. And April showed you the difference between Thunder Bay and Fort Severn. This process is further complicated by transportation challenges and the financial burden of travel, which often results in delayed care or missed appointments altogether. The combination of geographic isolation, healthcare shortages, and limited access to services all result in fewer opportunities for regular healthcare checkups. Regular screening and preventative care are essential for each detection and management of health issues. Without consistent access to such services, First Nation children and youth are at a higher risk for undiagnosed conditions and preventable diseases.
Environmental factors significantly impact the health and well-being of First Nations children and youth in northwestern Ontario. Climate change poses a direct threat to the traditional winter roads that many First Nation communities rely on for essential services like construction material, fuel, and food. Warmer temperatures cause thin ice and unreliable snow conditions, making these roads unpredictable and sometimes impassable. These disruptions not only increase living expenses, but also limit access to essential resources. Indoor air quality in First Nation homes is another significant concern, particularly during the summer months when forest fires become more prevalent. The combination of poor air quality and smoke can lead to respiratory risks for community members, particularly children and youth. Access to safe and clean potable drinking water continues to be a major issue for First Nation communities. Long-term advisories due to water safety concerns and infrastructure flaws are common. Additionally, many homes face inadequate ventilation, structural damage, and water penetration, which are all linked to higher rates of respiratory illnesses and skin infections. The social determinants of health, such as housing, food security, healthcare access, education, and environmental factors, are key drivers of direct health outcomes for First Nations children and youth. These determinants are deeply interconnected by the compounded historical, socio-political, and economic challenges. Addressing these social determinants of health requires a holistic, culturally sensitive approach that integrates healthcare services, education, and community-driven solutions. By tackling these barriers, we can significantly improve the health and well-being of First Nations children and set them on a path to a healthier, more empowered future.
Okay, so a key element of a holistic approach is integrating Indigenous knowledge and practices alongside modern healthcare and social services. Traditional healing methods such as ceremonies, storytelling, the involvement of elders, they all play a vital role in supporting mental and emotional health. It fosters resilience and strengthens cultural identity. By combining Indigenous healing and Western medical practices, we can create a more comprehensive care model that better suits the needs of First Nation children and youth. This approach acknowledges the importance of cultural connection in fostering a sense of belonging and well-being, while also providing access to modern resources. Incorporating community-driven solutions is another aspect in the holistic approach, and each First Nation community is unique with their own strengths, their own challenges, and aspirations. Therefore, solutions must be developed and implemented in partnership with community leaders and members. This grassroots involvement empowers communities, providing them opportunities to shape their own futures. Programs that focus on education, cultural revitalization, and youth engagement can equip children and youth with the tools they need to thrive. Addressing the systemic issues that contribute to the lack of the social determinants of health for First Nation children and youth in Northwestern Ontario requires advocacy and policy change at higher levels of government. Long-standing issues like inadequate infrastructure, poverty, and lack of access to healthcare must be fought through collaborative efforts between federal, provincial, and local governments. Indigenous-led organizations and leadership need to be involved, ensuring that policies reflect Indigenous ways of knowing and prioritize the health and well-being of our future generations. A holistic approach that combines cultural renewal, community-driven initiatives, and systemic reform will create a more equitable environment where First Nation children and youth in Northwestern Ontario will flourish.
SLIFNA's advocacy goes beyond research. We work to address the health inequities faced by First Nations children and youth across the 33 communities. Our efforts focus on improving access to healthcare, tackling the root causes of health challenges, particularly the social determinants of health. We work alongside community leaders and members to develop and implement solutions that are rooted in local knowledge and traditional practices. The 3 reports that I've highlighted are just a few of many that we've written, all of which include recommendations for improving our communities. The Mental Health and Substance Use Report, titled, I'm not going to say it, but it's titled in an Anishinaabe phrase, which translates to the hard things in life or stories about the bad state we're in. This report examines mental health challenges facing our children and youth, and looking at lasting impacts of intergenerational trauma and cultural disconnection. It addresses the rising rates of substance use, noting that mental health issues such as anxiety, depression, and substance use are prevalent, and calls for urgent investment in culturally competent care. The advocacy efforts that were highlighted is that we advocate for increased mental health services, the integration of traditional healing practices alongside clinical care, and greater investments in community-based mental health programs that empower local leaders to address the specific needs of children and families. Here's the reports if you guys wanted to access them. The second report is the diabetes report, which focuses on the rising rates of type 2 diabetes among our First Nation communities, particularly among children and youth. The report explores factors contributing to this increase, such as limited access to healthy food, lack of physical activity, and high levels of stress. The advocacy efforts highlighted is that we would promote healthier lifestyles through community education programs, improved access to nutritious foods, and better access to healthcare services for diabetes prevention and management. And then the third is the Food Affordability Report, which highlights the significant barriers faced by our First Nation families in accessing healthy, affordable food, particularly in northern and remote communities, where high cost of nutritious food exacerbates food insecurity. The report reveals that the price of a basic healthy diet is disproportionately high, making it unaffordable for many families. The lack of access to nutritious food contributes to increased rates of diabetes, heart disease, and other chronic conditions. The advocacy efforts highlighted is that we advocate for policy change aimed at reducing food costs, supporting community-driven food sovereignty initiatives, and improving access to traditional food sources. At SLIFNA, we are committed to increasing resources and funding for healthcare access, reducing food costs, and supporting mental health initiatives for First Nations children and youth. By partnering with communities, healthcare professionals, policymakers, and organizations, we ensure that the voices of our First Nation communities are heard, their needs are met, and their rights are respected.
Our calls to action. So SLIFNA continues to advocate for change, but lasting impact requires collective action. We have listed key areas where your support can make a difference. The first one would be considered, I'll read a few short-term calls to action. Expanding healthcare access and increasing access to healthcare services through telemedicine, culturally relevant health programs, and mobile health clinics that bring services directly into the community. Overall, improving the access to timely healthcare. Secondly, would be strengthening community infrastructure and advocate for equitable investment in housing, clean water, transportation, and sanitation. And ultimately reducing preventable diseases, addressing overcrowding, and creating healthier environments. Thirdly, supporting traditional food systems and supporting community-led food sovereignty programs and initiatives, protecting and restoring traditional food knowledge and practices, ultimately promoting health and cultural revitalization while also addressing food sovereignty.
The long-term calls to actions are advocating for policy change, work with policymakers to address historical injustices and ensure equity in healthcare, housing, and other essential services. These changes can create lasting improvements in health outcomes and community well-being. The second is to promote environmental sustainability. Advocating for policies that promote sustainability and resilience against climate change protects the environment from protecting the environment is important to ensure continued access to the North and sustainable living conditions for First Nation communities. To achieve this goal, we need collective effort and advocacy. Every individual, every organization, every policymaker can play a role in supporting community-driven solutions, dismantling systemic barriers, and ensuring First Nation children can live healthy, fulfilling lives. Real change is possible when we work in partnership with First Nation communities, respecting their rights, knowledge, and culture. It's time to take meaningful action to ensure First Nations children and youth have the same opportunities for health and well-being as others do. Work together to bring systemic change and ensure that every child can thrive.
I have the pleasure of sharing a story of hope and resilience with you. If you just bear with me for 1 minute. Losing space. Okay. Do we have her? Yeah. So right now, I would like to read a story to you. Hope and resiliency. So originally, from an Indigenous ancestry, her life took a dramatic turn before she was even old enough to understand it. At just over a year old, she was placed into the foster care system, a decision that would set the course for a childhood marked by instability, trauma, and painful disconnection from her cultural roots. Her earliest developmental milestones and first memories were not formed with her biological family, but in homes of strangers, foster families who in many cases were unable or unwilling to provide the care, the love, and emotional safety every child deserves. Throughout her childhood, she faced a multitude of barriers of healthcare that shaped not only her physical well-being, but her emotional and developmental health as well. Growing up in foster care, she experienced the kind of poverty and instability that left leaving scars, ones that many children carry quietly and invisibly. Malnutrition was a constant companion in her early years. She often worried when and where her next meal would come from. Most days, the only food she remembers was a morning meal provided at school. Hunger became part of her reality, a physical and emotional emptiness that made it hard to focus, to grow, and to feel safe. Her health suffered because of it. She was sick often and plagued with vomiting, fevers, fatigue, stress. She missed long stretches of school, and compounding the problem was the lack of consistent access to health care. She didn't receive routine childhood immunizations or vaccinations until later in her teens after she was in an adopted placement, meaning that she went without essential preventative care for years. And it wasn't until she was in her teens that she entered a more stable home environment that her healthcare journey began to catch up. The conditions she lived in were deeply inadequate. One foster home didn't even have running water or plumbing at all. Basic needs no child should ever have to go without. She remembers having rashes. She remembers having lice. And the embarrassment and the isolation and discrimination that came with it. It made her feel dirty. It made her feel less than. And it made her feel different. The stigma stayed with her long after the rashes and the lice were gone, internalized as shame and reinforced by the silence around her suffering. Her pain wasn't only physical, but emotional too. She once mentioned that she was lucky enough to have only moved to 5 different foster homes, one being a home where the foster parent suddenly passed away, being thrust again and then again into different emergency placements. Grief and fear mixed with deep heartbreak of being uprooted yet again. She left with nothing on her but the clothes on her back. There were no toys, no keepsakes, no comforts of home. The message was very clear. Nothing is permanent, and nothing belongs to you. She lived in low-income homes with no access to stable resources and no consistent support network to help her process what she was going through. Learning delays went unnoticed. There was no one to advocate for her. As a visible minority in care, she faced systemic barriers that compounded the trauma of displacement. And even deeper than all of that was a disconnection from her own identity, a forced removal from her culture and people, as she hadn't yet understood. It wasn't until later in life that she learned her biological mother had been a survivor of residential school, part of the legacy of institutional harm and intergenerational trauma that has impacted so many Indigenous families. That knowledge reframed so much of her experience, and it gave context to the pain she had carried, and yet sparking a journey of healing. Despite everything and all that I had mentioned until now, she found a way forward. Through counseling, education, cultural reconnection, she began to reclaim her voice, her identity, and her inner power. Access to healthcare improved because she was brave enough to seek it. She was heard. She was seen. Learning and learning became a passion of hers, especially in areas that related to children's health and advocacy. The same system that once failed her became the focus of her work, her purpose, and her voice. She also found family, a loving husband, 3 children who are the joy of her life. Through them, she experienced the love and stability she longed for as a child. And through her own growth, she discovered that she could live in a state of well-being and peace far beyond what she even thought possible. Her story is not defined by trauma. It is shaped by resilience, by survival, by the quiet, ongoing choices and decision to heal. And in that healing, she found strength, cultural pride, and a mission to ensure that no child feels invisible. What began as a story rooted in adversity has become one of reclamation and hope. Today, she walks forward with gratitude for her family, for her culture, her education, and her voice. She is a survivor, a learner. She is a mother and an advocate. She is proud to say that she is still healing and still growing. This is my story. And the only way I was able to share it with you today was saying it in the third person. So my apologies. There might be some of you here today that may relate to parts of my journey, or who have heard of stories that are even more heartbreaking. And it's for that very reason that so many of us do the work that we do. It's why we show up with passion, with love, with empathy for the children who are still living this reality and who are still living these stories. Children who are waiting to be seen, to be heard, and to be believed in. Because sometimes all it takes is one person or your vocational passion to change the course of a life, to offer a spark of hope where there was only fear and silence. Let's keep showing up, and let's keep listening, and let's keep fighting for a world where every child has a chance to heal and to belong and to dream. Thank you so much for letting me share. Chimigwich.
Thank you. Sorry, I just would like one more slide. So from our mental health and substance use report, my very first time picking it up, I flipped through the book and I flipped to this page. But this book carries so many stories. And I would like you guys to take a minute to hopefully read through it. I'm going to read you one little excerpt from it. It says, "Letters from a Son" by Joshua Beardy. "To Dad, the most powerful tool you gave me was raising me up on the land. All the camping, hunting, and fishing have given me deep-rooted connections and memories. They have helped transform me into who I am, become a part of who I am, and I'll never forget what I learned. The land demands respect, as we must respect ourselves and each other. The land provides as we must provide for ourselves and each other. The land provides, the land can be peaceful and warm, but in a moment become violent and cold. We must adapt to our environment just as quickly. The land provides many teachings about the difficulties and beauties of life and ourselves. The land provides many healing medicines for the mind, body, and soul. The land kisses us with splashes from the river, winds in our face, and floating flakes of snow. We are all from this land. One day we will return, each and every one of us. We are land. So again, I am most grateful and humbly thank you for raising me to be a part of this land. Your son, Miigwech.
Thank you. Now we have some time for questions, so please come to the mic if you have a question to ask. That's okay with you.
Thank you. That was a beautiful presentation, including your story. Thanks for sharing. I'm a department head of pediatrics and child health, Manitoba. Many of the stories that you shared resonate with me deeply. In 2020, you may be familiar with the report by the Centre for Healthcare Policy in Manitoba, which talked about the health of Manitoba's First Nations children, showed somewhere in the realm of 40 times the rate of type 2 diabetes, suicidality, substance abuse for children. Among other things, preventable diseases like acute otitis media. And it really led to a conformational change in our department of how we approach Indigenous reconciliation, Children's Hospital. But one of my colleagues, our Indigenous health lead, Dr. Melanie Morris, said to me after the report, "How is this okay?" And it is a question I continue to ask every day. How is it okay that we allow these preventable diseases and these diseases that would be considered minor in our own communities in Winnipeg and suburban Winnipeg? We start to focus on the impact of residential schools, and I encourage people in the audience who aren't familiar with the history of residential schools to read. It's a matter of public record. And government records will show that this was intentional. It goes beyond cultural assimilation. It was a cultural genocide. And it helped me as a health systems leader understand what intergenerational trauma truly is. And I think about it in the context of my family members, my nieces, for example. They were removed from their home and lost their cultural identity. Their mothers, their fathers, their culture, and then put them back into society and expect them to integrate and not experience mental health issues, physical health issues. And so my message to those who aren't familiar with the Indian residential school system is to read about it. It is so difficult to read. I can't read through it all. I teach in the faculty, in the Indigenous health faculty, and every time I teach in that program or proctor tutorials, I'm just astounded at the level of trauma that Indigenous children faced. About 25 years ago, when I was a resident, one of the norms of my rotation during pediatrics when I attended high-risk deliveries was forced sterilization. Nobody even questioned it. It just happened. Or the forced removal of children who were infants who were deemed to be in vulnerable homes. And thankfully, those practices have stopped. But to those members of the audience, I think, who are not familiar with the Indian residential school system, I encourage you to read about it because I think our activism has to be collective. Thank you.
Thank you for the comment. Any other questions? There's
over here.
Okay, go ahead.
Hi. I just wanted to say thank you so much for sharing such an impactful story. I've in my master's, I actually did some work with Sioux Lookout. But I just wanted to touch upon a point just because there's a lot of researchers in the room, just the meaningfulness of that engagement. So would you suggest, I guess, cultural liaison is sometimes what they call them, but having someone on your team to navigate how you wish to do your research? So I'm just curious if you guys have like a sector for that, or if you know of people who work in that space.
Thanks for sharing. So we are a part of the public health branch in our organization, but yet we have a team that would be data analysts and an epidemiologist. And when we do pursue our research, we do it together as a team. We actually join with other programs within SLIFNA and join the senior management executive level. So we do make sure that there's plenty of time, to collect the data. It takes a long time. We are a province with tribal councils. And so it's more, we do need to respectfully collaborate with those tribal councils and leaders. It's like the chiefs, the council, and they need to know that we're utilizing their feedback for our data. And every single community on that map that you saw in the SLIFNA communities, they are the owners of their data. Yeah, so it takes a long time, but we do on a very tiny, small scale, are able to provide a research team, and these reports that April had shared within the presentation, they're all just within the last 3 years. Yeah, and not the best news, but some of the first reports that have come out for our region, ever. Thank you for your comment.
Any other questions from the audience? One of the things that came to mind as I was listening to you, and thank you. I know that it takes a lot of courage to come into these spaces and share personal stories, and also, sort of face a lot. There's a lot of people who maybe don't understand or don't have that knowledge. So thank you for bringing that today, and thank you for being courageous and doing that. We you talked a little bit about traditional healing and incorporating that. I'm wondering if you can tell us a little bit about, do you have some programming or that you can share how you bridge that?
Sure, I will speak to this one. So, my program, I am the acting Raising Our Children manager, and in the program, we have 2 sections: family health, which focuses on the mother's, the baby throughout pregnancy, and then we have the youth component. So, our youth team this past weekend hosted a camp. It's a peer education camp. So we put out words around social media, send to the tribal council, send to whoever we think would benefit for this programming, specifically programming for to us LGBTQ+ this past weekend, where we incorporate our cultural team at SLIFNA. We have Anishinaabe, and they come with traditional knowledge keepers and elders. So they help us and they support us in programming that we provide to the youth. Thank you.
Okay. So I have lots of questions, but I won't take up all the space. But and you talked too about community-driven solutions and sort of the importance of connecting, like shaping communities and nations and reserve being able to shape their own future, and having the community-driven solutions. And I know a lot of times systems we try to tell people like this is what you need, and this is. Do you have ways of maybe sharing that you can ensure that the communication is coming back, and the community is their voice is being incorporated or being heard and implemented instead of just being on the receiving end?
Yeah, I can answer a little bit to that. One of the questions was about research, and one of the biggest things that we can utilize right now in collecting feedback is surveys. And we make sure that it's, a specific age group that we're focusing on. We want to hear from that specific age group. And we want to hear from all families if we possibly can. We want to hear the hard stuff too. We want to hear it all. It takes thick skin to hear what we might be doing wrong or what we might be saying, and telling them that it's not their way. Because every single community is their own unique, community, and they have their own unique challenges. And we need to come in and understand that. So that means that the dynamic of family, the way that a child is raised up until adult, and the way that, they're taught at a young age to survive off the land, those are very important things to carry on. But each community is so diversely different. We need to just be respectful in that manner. I think that one of the things that we have done at SLIFNA is we've provided a lot of different programming that would focus on the different age groups. Like April mentioned, prenatal, perinatal, babies, youth. And then there's other programming where nurses are in the community and they're focusing on, in the public health branch, all of the catch-up that's needed. And that was mentioned. And then there's other programs too that bring in specific, very clinical development services, as well as the much needed primary care and acute care. So in all of that, we know that we need to come and have that perspective of we need to take the time to build relationship. And if we go in and do our services and we don't, we've become just like the broken system that is surviving in Northwestern Ontario region. We don't want to replicate that system. So we're trying to be the positive change and providing that communication and especially that relationship with members in the community. Again, just I really wanted to state that each one is so diversely different. And there are 33 communities that we serve. And it's such a pleasure. Does that answer your question?
Yeah. That was great. Thank you. Another thing that we talked a lot about in terms of, and you touched a bit on this with research and having the community involved with surveys and taking that approach. But we talk a lot about knowledge mobilization and getting public health messaging into the public and into communities. Are there any messages you can share about, or examples you can share about how messaging is best delivered and shared?
That's a broad thing. Sometimes from feedback we get, they love having in-person sit down with us, and that's part of the building connections. But oh gosh, my brain is I lost my train of thought. I'm so sorry. Knowledge. Okay, yes. So I'm going to give you a prime example. During COVID, we were noticing a low uptake of education in prenatal care. So the way that we tried to accept, and you can't go into community. During COVID, it was actually crazy having to deal with 33 communities and outbreaks. But on top of that, they were still living their normal lives, having babies. So we wanted to make sure to get that message out to them. And we had to figure out a way. So we created baby bundles. And these baby bundles incorporated supplies that they would need, such as breast pads, pads, cleaning supplies to help clean baby bottles, toys, different books, but also resources, specifically on safe ways to have your baby sleep, food of what you should be eating, very, very specific resources that we wanted them to have. And that's the only way that we had found it was best for us in the COVID pandemic. But that's an example. Thanks.
Right. Okay. If we don't have any other questions, oh, we do. Good.
Sorry, I had to actually compose myself before I could stand up because your story was so moving. My name's Melissa. I'm the manager for CHEO's transport team. And although we don't go into your region, we do service all the way up to Attawapiskat. And one of the things that coming from adult medicine struck me when I started working in this world is how many women in your communities show up to deliver out of the blue without any prenatal care at all. And the reason being, if it is discovered that they are pregnant after a certain number of weeks, they're removed from their community and they have to live in a city where they don't have a support system. And, honestly, who could blame them, right? But ultimately, when you think about the outcomes for the infant and the mom, that it's a system that we have. The intentions, I think, are somewhat good in the sense of we want you closer to the kind of care that you may need. However, understanding what the trauma would be for those people is something that I'm trying to do better at. But my question to you is, what kinds of technology are there available in some of these really remote communities that would at least enable other family members to connect with the one that maybe has left because they are getting prenatal care, or they've delivered and unfortunately the baby has needed our services and they're taken, I think London, Ontario actually is who services you. So if you go from Fort Severn all the way down there, that is just an unbelievable distance. So is there any opportunity for, whether it's Zoom or FaceTime or anything like that, that you have seen used that could hopefully make that connection for those people who are probably feeling so alone and scared and not supported in their community?
Thank you so much for sharing. And just real quick, I just wanted to state that I'm married to a First Nation member of Deer Lake First Nation, and he is the first generation born in hospital. So his parents, his great-grandparents, and on, were all born in the bush or on their trap line out in the bush. So that kind of just gives you a little bit of a picture. Those my age, most of us would be considered first generation and having access to these kind of services before, and those babies born in the bush, they were basically just completely taken care of by their community CHRs or community health reps. And they were the ones with the expertise in the area. So now I think that there's a lot of collaboration happening. We're an organization of 700 staff, but we still consider ourselves small because there's so much need and all the different types of services that families and new mothers are needing nowadays. We're not big enough, believe it or not. And so we're doing a lot of collaborating with. So we call them regional hospitals. We do have contacts. Sulukau is considered the hub, and we do connect with them. Their IPP clinic. We're doing the best that we can. All different pieces of the puzzle. We're trying to capture these young moms, because you know what? The last thing that they want to do is come out to community to have their baby, and they're all alone. And the last thing they want to do is stay. And call it a vacation. No, they want to get back home as soon as possible, unless something, comes that is acute, or, they're being sent down to London, which it does happen a lot. We're just trying our best to collaborate with the services that we can. As long as there's funding for other, existing programs, I think we'll be okay. But April's program and public health, like they realize the importance of getting that information out there, teaching in person, over tea and bannock, or she was saying during COVID, literally they were giving a swab all decked out. And it's like, hey, by the way, would you like some information? I noticed you're pregnant. So there was a lot of collaboration like that. You kind of just have to get innovative, right? And the different ways that we are able to share. There's just so much. And if any of you want to come work up north, great, let me know.
Thank you.
Hi, my name's Kelsey, and I'm the house manager at Ronald McDonald House in London. So we see all of your families that come to London for treatment. So I'm kind of outside of I'm a healthcare partner, and I don't know, this can be a side question too, but we're in the process of redesigning and expanding our program, and we're really we've already started planning for Indigenous healing space within our facility. And so my role is to essentially create a home for a very diverse group of people that come to stay with us for a variety of reasons. And so I'm always on the lookout for different connections, and especially with our Indigenous community. I have partnered a bunch with our Indigenous Healing Center at LHSC, just to get some different ideas of things we can incorporate into our program that would feel like home for all of our families that come from all the variety of places. And so don't know if I have a real question, but just if you have any insights, or if you can lead me in the right direction of community members that I might be able to connect with to get ideas to just make sure that the house feels like a home for everyone that does come and stay with us, I would really just love that.
Yeah, it is kind of hard to pull out a question. but I mean, you could always connect with April here, and she does have access to the public health, portion of the Raising Our Children in our organization, and it might just be a really fantastic conversation that you can have, I think, and can definitely give you some ideas for sure. That would be culturally appropriate and sensitive.
Thank you so much.
Yeah. Go ahead.
I just also would like to say that when taking opinions about First Nations people, it's always good to check in with the home community as well. So even though you're looking at seeing multitudes of people, there are multitudes of First Nations as well. So different treaties, contacting treaty council, that type of thing. Have a working group, get started. With the Sioux Lookout First Nations Health, with Minneawan. Minneawan is the hub of the North, which we had spoken about in Sioux Lookout. They took consideration for all of our communities up north before they built the hospital in 2010. So in the middle of the main building is a fire, and dirt from 33 communities are put in the center because they thought of our First Nations when building the hospital. So, excellent question, and I would like for you to reach out to tribal councils.
Okay, we're just about out of time here. So if you can help me in thanking Karen and April for joining us and sharing today, that would be wonderful. And we've been given some calls to action. So if you didn't grab a shot of that, the slides, we'll make sure that they're available to you. And just on a housekeeping basis, actually, I don't know if I have the QR code, but the next, there we go. If you could fill out your evaluation, that'd be great. And then the next session is here in this room, inspiring child health leaders for the future. Yeah, just the future. So thank you for that. And thank you for joining us today. And thank you, April and Karen, for sharing with us.
Thanks.